My name is Dr. Stanley Franklin. I'm clinical professor of medicine at the University of California, Irvine. And the topic of my presentation is how important is white coat hypertension for the appropriate treatment of high-risk patients with isolated systolic hypertension. Now, isolated systolic hypertension has been a somewhat controversial entity in the literature for a number of years. And so we were especially interested in studying older patients with isolated systolic hypertension. And I was very fortunate to work with the 11-country IDACO group centered in Leuven, Belgium. And we were able to identify a group of subjects with isolated systolic hypertension by clinical office pressure, and then subject them to 24-hour ambulatory blood pressure monitors. And what we found is, first of all, isolated systolic hypertension is much more common in the elderly patients. Indeed, there were slightly more than half of the patients who had isolated systolic hypertension as those who had sustained hypertension. And then when we threw in those with masked hypertension, which made up about 9.9% of the so-called normotensive individuals, it turned out that if you use the office or clinic blood pressure alone, your misclassification is 73%, almost 3 out of 4 individuals. So that was quite a surprise. But the second, and perhaps even more important information from this study, is that many individuals who present with treated white coat hypertension, if you look at the literature, many people used treated subjects to define white coat hypertension. But the original definition of white coat hypertension by Tom Pickering was in untreated, which I think is the appropriate way it should be diagnosed. What we found was that a significant percentage of individuals on treatment masqueraded as white coat hypertension because treatment normalized their out-of-office daytime ambulatory pressure, but because they had a white coat effect, they had elevated blood pressure in the office. And they had risk. They had more risk than so-called white coat hypertension who were not treated. So I think this was the second and very important finding of our study. So, and the third important finding was that, that those individuals who were untreated, who had true white coat hypertension, on average, over a 10.5-year follow-up period, had no greater incidence of cardiovascular events than individuals with true normotensive hypertension. And the last finding was that those individuals who had diabetes or were males, they had evidence of true hypertension, increased risk, so that and to summarize, the label of white coat hypertension should only be used for individuals who are not treated. But even untreated individuals with true white coat hypertension, if they have increased metabolic risk, such as you see in a diabetic, that these individuals may indeed have enough risk to require treatment for their cardiometabolic abnormalities.